Next is Dr. Linda Barr. She's a senior scientist at the Kaiser Permanente Washington Health Research Institute.
Thanks. That's who I am, huh? I wanted to thank the organizers, including Dan, for inviting me, and also to recognize I feel really honored to talk about integrative health modalities. There are many people, I'm just going to do that, many people in the room whose work I'm going to talk about today really is hugely important in the last couple of decades for a number of the conclusions and things that I will mention. So we talked a little bit more this morning about some of these modalities, but just wanted to say initially why complementary and integrative health for pain. So one of the things that's probably clear to everybody in this room is that these are things that are used very widely for pain. When you look at medical conditions, it's really the number one reason people are using these modalities. They're also often used for wellness, and there might be some real synergies in that we can talk more about. There have been some of the review presentations this morning that already underscored that we see at least small and consistent effects for many of these modalities for pain, and really importantly that there's very little evidence that there are serious harms. A lot of those things haven't been looked at real systematically, but it's particularly in the wake of the opioid crisis, a really important piece of why these modalities are particularly important. It's also the case when you look over the last 20 plus years that the way that we're looking at these modalities has changed somewhat. We moved from NCAM being NCAM to NCCIH, and I think along with that a recognition that rather than this being an alternative pathway, there's increasing, we've talked and we will talk about the problems of integrating these things, but much more interest in integrating these into conventional care, and I think that's important and promising. And then finally, some of the most provocative things that I'll just touch on briefly is that some of these health practices, we've talked about placebo and why that's what we need to control for, but there's increasing a real emphasis on maybe we should really be harnessing those effects, and really, especially when we're talking about pragmatic trials and things where we really are looking at real world treatment. Maybe it was a historic albatross, I will say, in terms of looking at mechanism, but it might be increasingly important and really a promising domain. There was nowhere to put this in the right place, but I was taking seriously the emerging models of care, and this is something really that we developed out of a pragmatic trial that we're almost done with, and it also builds on some of Michael von Korf's and other colleagues' work that we've used to really acquaint patients and primary care providers to thinking about providing care in a much more integrated way. And I would just note that many patients, when they're entering in the care in the simple places that Julie was emphasizing, spend a lot of their time in the lower right, really looking for magic bullets and using conventional practices. And a lot of these integrative care modalities really can help to probably drive folks towards more active approaches. Some of these approaches are included under the two quadrants at the top, but even some of the passive approaches may really underscore the importance of active patient self-care. This is from a very recently published study of the NCHS, the National Health Interview Surveys that are done every couple of years. This is not just about pain, but it is showing that these are kinds of modalities that are used very, very widely. These are the ones that are increasing the most. I know Dan gave me feedback like, why is massage not on there? And it's because this was an emphasis on what is increasing over time between 2012 and 2017. But this is in the general populace. Clearly, these things are popular and used a lot. Fortunately, I don't have to spend a lot of time on the slide because Roger went over it with such detail. Julie mentioned it as well, and just to keep it a little confusing, I've used the symbols in a little different way. But this is the recent ARC review, and I think the important thing about this review is that it set a somewhat higher bar, and that it said, let's look at enduring treatment effects, so at least 1 month post-treatment, and let's look at intermediate and long-term outcomes as well. I've bundled this into, I didn't put all the modalities here, but some of the things that are used most frequently, and what I will note is anything that's just got black means that we're really not studying it, at least in the context of these conditions, in a way that lended itself to really having robust evidence. But I do think it's important to note that there are several things here that are having at least impacts in the 1 to 6 month range, and those are on functioning as well as on pain intensity scores. But there are some things that ARC review and how we've been doing research really don't speak to. And again, colleagues have brought this up this morning, so I'll just say these things very, very briefly. And that is that we tend to get funded in ways that have led us to look at pain conditions in fairly siloed ways. But we know that many, many people, and probably most people, have chronic overlapping pain conditions, and we need to start looking at it in that way. I will credit my colleague Kurt Kroenke, who's talked a lot about also thinking about the kinds of symptoms that are co-writing, so sleep problems, anxiety, depression, and really making sure those folks are in our trials and that we're looking at the impact on those conditions. Also, a lot of the modalities, the CIH modalities, have been studied in more partitioned kind of ways, looking at needling instead of broadly TCM practices. And I would say that's true for chiropractic and even the way things like yoga are used. So how can we think about sort of the broader ways these are delivered? And then we've already noted that even though there's more interest in integrating these modalities, a lot of times right now they're pretty disconnected from conventional care. What is missing at the top of the slide is what is this looking at that I realized. So these are studies that were all done by my colleagues Dan Churkin and Karen Sherman, and represent just some really fabulous, rigorous clinical trial work over the last 10, 15 years. These are all for chronic low back pain. These are slides that Dan has presented elsewhere, so I'm sure others have seen those. But I think what is noteworthy here is that when you look across these different modalities, what you're seeing, and these are minimally clinically important differences that these are noting, is that all of these active modalities are showing very similar impacts, and they're all about the same amount over usual care. The number needed to treat here is 5 to 6 for all active treatments versus usual care, which I think is important. But it starts to, I think, bring up questions about what are the implications of how we should be thinking about how we use CIH modalities. And quoting Dan on some of his recent presentations, he notes the effects of patient and clinician credible CIH interventions may derive more from contextual, there should not be an R in that, effects of the care experience than from the specific characteristics of the intervention. So again, an idea that we really need to maybe start looking at some of these non-specifics in a more systematic way. How to think about it, some of these things? Well, maybe it's less important which modality than we really think what's available to patients in a particular area. What are they excited about? What will they commit to and adhere to? And maybe we can start to do our research in that kind of way. Others have mentioned earlier, too, that maybe we can sequentially and think more thoughtfully about how we employ the active versus the passive modalities. And I would say even with the passive modalities, which acupuncture, spinal manipulation are often put in that category, when you do care or where you do research in real-world settings, those practitioners really emphasize how they feel like they're one step in the process, and what they're really trying to promote is to people being really active in the self-care. This is a slide from a publication of Alia Crum and colleagues, and she's done some really interesting publications last couple of years in The Lancet and BMJ, really talking about the importance of mindset, how we think about that in a systematic way. Something I didn't put up here, but I would encourage people to look at, is that there have been some very provocative studies done on placebo effects when we call them such and say, I am giving you an inert pill, and as far as we know, it doesn't have an impact. So Ted Kapchuk and colleagues have done work on irritable bowel syndrome, and then he collaborated, as did Irving Kirsch, who's done a lot of work with placebo effect with Claudia Carvalho and colleagues in Portugal. They did a study on low back pain, and it's interesting the translational differences. They called them flower pills, and looked at what the impact was. And I thought it was interesting the way that they set this up. They said the points that they emphasize is the placebo effect can be powerful. The body automatically can respond to taking placebo pills like Pavlov's dogs who salivated when they heard the bell. A positive I'm on red. Goodness. Okay, I'll stop in just a moment. Positive attitude can be helpful, but is not necessary, and that it was important to take the pills very systematically, and found very strong effects with this, and that almost half the people asked for the placebo pills after the end. So I'm going to stop there. I think I introduced the important things here. I will say here that the quote on the right was from an acupuncturist, and it sort of underscores what I was talking about. And they noted the most important thing about is the initial connection you make with the patient, that the connection is critical, and that the number one thing this person said is they sell hope. I hate to admit this, but it's one thing Western medicine does badly. So hopefully that introduced some provocative ways to think about these things. Thanks.